Welcome to the session on harnessing surveillance data to improve individual patient retention and re-engagement in HIV treatment, the next steps towards data to care for epidemic control. My name is Kristen Stafford. I'm an associate professor of epidemiology and public health at the University of Maryland, Baltimore, and serve as our deputy director for our Center for International Health Education and Biosecurity. I'll be co-moderating this session with Dr. Mahesh Swaminathanf, the CDC country director in Nigeria. Since the inception of PEPFAR, the arc of data use has rapidly bent from predominantly aggregate data for reporting purposes to patient-level data, including case-based surveillance, and is poised to take the next step to patient-centered data for care systems. I say rapidly because while 16 years feels like a long time and a lifetime for some of us, low and middle income countries have gotten to this point in about half the time it took us in the United States and Europe to get here. Data to care takes case-based surveillance a step further by working across partners, funders, and facilities to enable the deployment of specialized interventions to re-engage patients who drop out of care or identify those at risk of stumbling out of the care cascade. Data to care helps move the data value chain to truly start and end with an individual client. We're excited to be joined today by Dr. Elizabeth DiNenno, the Associate Deputy Director for Surveillance and Epidemiology and Laboratory Sciences at the Division of HIV/AIDS Prevention at CDC, Dr. Max Kapanda, the Principal Medical Officer for the National ART Program in Botswana with the Ministry of Health and Wellness, and Dr. David Lowrance, the HIV Surveillance Lead with the HIV Department at the WHO. They will discuss gaps, challenges, and successes, as well as lessons learned in this area. I'd like to now turn it over to Dr. Swaminathan for his opening remarks.
Thank you so much, Dr. Stafford. And I think we're very excited to these presentations. You know, I think what I've observed in my career, working both in the United States as well as overseas, is really at the speed of implementation in developing countries where with a high HIV burden. And part of that there has been some advantage in that certainly countries like the United States as well as Western Europe have actually taken a lot of time in setting up their case surveillance systems and have really shown in some level how to make it work. But what I would also say is that in developing countries, particularly those in sub-Saharan Africa with a very high HIV burden, there are challenges that they face that aren't necessarily faced by low burden countries in resource-rich contexts. And so it's very exciting to see these presentations. And I think one last thing before I turn it over to the presenters is that what I think is very interesting is that we're now going to start talking a little bit about how the use cases for patient data, whether it's surveillance, monitoring, evaluation, and patient care, even though we're using the data for different purposes, the lines between these different use cases are fuzzy. And so that any surveillance system, any MAE system, value to providing services for patients, and that when we're thinking about these systems, we should be thinking about these different domains. Obviously, these domains have their own needs and their own concerns, but still that these are part of a way thinking about these data systems as a way to really meet the needs of an entire program from the highest level where we're talking about decision-making, resource allocation, epidemiological analysis, all the way down to the clinic level where we're thinking about the health of individual patients. So thank you very much for the opportunity to co-moderate this session, and I'm looking forward to the presentations.
Hello. I'd like to start by thanking the organizers for the opportunity to participate in this important session on optimizing use of routine program data. My comments will primarily be directed towards efforts to ensure that WHO guidelines drive impact through person-centered data use at country level. As a normative technical agency, WHO's core business is the development of clinical guidelines, such as these, which define evidence-based recommendations for quality HIV health services. These clinical guidelines are also the foundation of WHO's strategic information guidelines. And together, these guidelines inform the health sector response to HIV and catalyze progress towards strategic goals, including 95-95-95 and the Sustainable Development Goal of ending AIDS as a public health threat by 2030. There are two primary guidelines on HIV strategic information: the consolidated and recently updated SI guidelines on the left, and the 2017 person-centered patient monitoring and case surveillance guidelines on the right. Generally speaking, these address collection, reporting, and use of aggregate and individual level data, respectively. Together, these two SI guidelines on HIV health data support all relevant data use cases, from patient care, most fundamentally, to global monitoring. They include recommendations on both the type of data elements and indicators to be collected and reported from facility and community-based services, and how these data should be best used to improve care, service quality and access, and ultimately to measure and monitor impact. As shown in the above examples, HIV SI guidelines define strong links between individual level and aggregate data. This interrelationship is best captured in the phrase, collect once, use many times, which underscores the concept that health information systems are most efficient and most effective when they apply consistent standards and avoid duplication and redundancy of effort while serving multiple purposes. Within the same data use pyramid, the red rectangle seen here is intended to illustrate the collect once, use many times principle, defining a priority or minimum data set which cross-sects all data use cases and which is at the heart of effective health information systems. Now let's talk about two of the most essential issues with individual level data featured within WHO guidelines. First, too much data and unused data can be counterproductive. So it's important to prioritize. Care providers, guidelines developers, and program managers need to make good choices about whether or not to include data in routine data collection tools, and to ensure that these tools, particularly digital tools, provide decision support, such as health alerts, to prompt action when most needed. Case surveillance data, which reflect a subset of priority data often drawn from individual level data systems, are intended to enable simplified data management, analysis, and use. Secondly, deduplication of client records sounds simple, but it's not. Policy and technical aspects of unique identification can take years when done well. However, this is truly the crux of realizing the full benefits of individual level data, which enables person-centered care across an entire health system, as opposed to limited to a specific site, project, or geographic area. At this point, we've covered a lot of key concepts within our guidelines. Now let's consider a specific example, retention among PLHIV on ART, in order to better distinguish the different data use cases supported by individual level data. Starting in the upper left corner, we have patient care and monitoring. HIV care providers have a primary interest in ensuring that the health information that they record has a direct benefit for their patients, including helping to ensure that they remain retained and adherent on ART and have undetectable viral loads. They often use EMRs or similar digital systems for this purpose. Ideally, these systems provide or enable decision support, such as health alerts, when individual patients have missed appointments. Moving clockwise, facility managers and surveillance staff supporting service delivery in their catchment area also want to understand population health, including key performance measures such as ART program retention. Based on individual level data, an aggregate retention indicator allows facilities to know where they need to perform deeper data dives and/or allocate more resources to strengthen retention. In some cases, a dedicated data repository may be used to facilitate analysis and use of these data, especially when deduplication of records is warranted. In the lower right, aggregate reporting on the number of PLHIV on ART at higher administrative levels, including national, is vitally important for monitoring targets in multi-year strategies or grants and/or annual operational plans. Again, these aggregate data are almost invariably generated by individual level data sources. And finally, in the lower left, global monitoring data provided by countries to technical or donor agencies reflect all of these other data sources. Information drawn from WHO's Digital Health Atlas illustrates the high number of aggregate and individual level data systems in low and middle income settings, including many countries in sub-Saharan Africa. The numbers shown here reflect consolidated figures for geographic subregions. In light of this rapidly evolving digital landscape, WHO has initiated development of two related global goods, which we expect to be available by late 2020. First, we're working with partners to develop a digital health accelerator kit for HIV. At its core, the kit will provide the knowledge content within our existing clinical and SI guidelines in new formats that can be more readily incorporated within digital systems, leading to greater alignment of and fidelity to WHO standards. Secondly, due to the persistent implementation gap in individual level data use in many settings, WHO will launch a case surveillance data use implementation package later this year. There are two components of the digital accelerator kit highlighted here in the red circle, which are of particular relevance to the goal of promoting individual level data use at the patient and service delivery levels. The core data dictionary includes the data elements and indicators required for clinical decision-making and mapped to available terminology and data standards, which facilitates health information exchange that is essential for robust data use. The complete decision support logic helps to ensure that digital systems are generating appropriate and timely guidance to care providers regarding the health status and needs of their patients. The case surveillance data use package will include a DHIS2 tracker-based configuration with standard metadata and user interface, analytic dashboard visualizations, and associated exercise curriculum to facilitate and build related capacity in data reviews and use and program an improvement of patient care and services at all levels of the health system. The HIV case surveillance data use package will address differentiated data use. Specifically, the package is developed to respond to two primary country needs. First of all, in settings with existing national individual level data systems, the configuration may be used as a data repository for management, analysis, and use of case surveillance data. Secondly, in settings without existing individual level data systems, this configuration package could be used directly or indirectly as an efficient solution to advance all data use cases. Finally, as seen in the figure on this slide, one of the issues that this package will address is the comparative advantages of individual level data over aggregate data and context-specific considerations in determining appropriate investments to optimize data use. In closing, let me say a few words about WHO plans to launch the first ever fully consolidated SI guidelines next year. This new global good will effectively merge and streamline both existing SI guidelines. For the first time, the guidelines will incorporate end user inputs on existing guidelines and emerging data needs. They will also address individual level data use within primary prevention services as a basis for measuring and monitoring HIV incidence and within integrated health service models. As the next stage of evolution from the digital accelerator kit, WHO plans to launch intelligent or computable guidelines in 2021. These products will include updated content on health information exchange and system interoperability, unique identification, and data security. These updated guidelines will be an important opportunity to consider ways to strengthen technical recommendations on using data for care, as seen in the presentations made by WHO member state organizations represented in this panel and beyond. And we look forward to your contributions going forward. Thank you.
Hello, ladies and gentlemen. My name is Max Kapanda from the Department of HIV/AIDS Prevention and Care in the ART program in Botswana. I would like to share with you our experience on data to improve health outcomes from Botswana. The outline of my presentation will talk a little bit about the background of ARV program and also the data, how it's used in the ARV program. Then I'll talk shortly about our experience on use of case-based surveillance, then also talk about the way forward. The ARV program in Botswana was launched in 2002 with the aim of providing ART free of charge to all citizens, HIV positive citizens eligible for that. And at the start, we had around 110,000 patients on treatment. And currently we have more than 320,000 patients receiving care across 565 health facilities in the country. And it's very important to note that more than half of our patients are currently aged over 40 years, which gives a rise, implies that there is a rise in the comorbidities, mainly the non-communicable diseases. So that being the situation, there is a need for a more integrated approach to care to monitor patients' level data, to know like who is dying from what, and to know how our patients are being affected. So my presentation is, our experiences focuses on HIV, but basically our intent is to move, to bring in or to look into all other comorbidities. One of the challenges that we experience in our system is that in our provision of care, especially when data use is concerned, is the multiplicity of data sources. That means we have a number of electronic systems that are used in different health facilities. We have the use of electronic registers, and we still have facilities that are paper-based. So that makes it a little bit impossible or difficult for us to generate longitudinal patient-level record. Despite the fact that we have a data warehouse, which actually is a repository for all the data received across the facilities, that this data usually comes like aggregated data, and it's not feasible, not possible for us to generate HIV case report. The shift to announce, sorry, there was a slide. We feel that there is a need for us to shift, the way we monitor patients. Hence, the only way forward we thought was the introduction of the case-based surveillance, which helps us to link multiple data sources in order to derive patient information that we need, and also to deduplicate individual level data on the diagnosis of HIV case from all the health system. And also the system can, is able to allow us to trigger responses that can alert HIV clinicians, healthcare providers, and even decision makers to situation or gaps that are happening on the ground in order to provide solutions. So case-based surveillance is basically a patient-centered approach, a way we would like to use information, strategic information for any disease, starting from the HIV care standpoint. Our experience on or the project we had on use of case-based surveillance started in late September, October 2018. This was basically in the facilities that are supported by PEPFAR. So from the time we started up to June this year, we managed to enroll into DHIS2 about 250,000 patients, which is more than 2/3 of our patients on treatment across 52 facilities. And this has helped us to collect some of the indicators that we have set ourselves to be collecting through case-based surveillance, to collect the HIV testing, to collect linkage to care, ART initiation, CD4 follow-up, viral load suppression, retention to care, and so forth. On this slide, as you can see, the green, the indicators in green are the ones we have actually managed to collect, and those in red are the ones that we could not collect. We failed to collect because of various challenges like incompleteness of data, inaccuracy, and some missing data completely. The improvement of the patient outcomes through CBS have been observed in a way that we were able to find, to come up with interventions that are targeted to the reality on the ground. For instance, CBS helps us to find the missing people living with HIV, missing patient in care, the lost to follow up, those who are not linked to care after diagnosis, and also those who are not virally suppressed. I mean, those for whom the treatment is not working. In addition to HIV treatment, PMTCT has been one of the areas where we think that case-based surveillance will help us have a better, build a better cascade to pave a way to the elimination of mother-to-child transmission. And most importantly, as the program, we have been introducing the differentiated care of model that came with the introduction of Treat All in our provision of HIV care. So this case-based surveillance helps us to target our intervention to the patient's needs, specific patient needs. This is a screenshot of DHIS that shows us one of the outcomes from the use of case-based surveillance, where we were tracking the ART initiation, because as we talked of Treat All starting 2016, we also introduced the concept of fast tracking of ART initiation, which simply means in our context, we want people who are diagnosed HIV positive to be put on treatment within 7 days or the same day of HIV diagnosis. So on this graph, we can see that we could see that most of our patients, the number of those initiated on treatment either the same day or within 7 days of HIV diagnosis were ever increasing, while the number of patients initiated on treatment later than 7 days was actually going down. And again, here you can see the viral load suppression among pregnant women across the different districts. This is the rate of viral load suppression, also as we're monitoring our patients through case-based surveillance. Case-based surveillance is actually a tool that we are going to use to link our client to HIV services, irrespective of the service point they get to in the facility. And also it helps us to identify gaps at each level, facility level, patient level, district level, and to tailor the intervention in the part of our differentiated model of care. And in addition, we also want CBS to help us to be to avail data to the clinicians, the healthcare workers, and the decision makers to access it, to visualize, analyze it, and then target interventions. So here you have a few pictures of healthcare workers discussing over data. What is the way forward? We want to expand the case-based surveillance over all our facilities. We want to make sure that our healthcare providers and the program implementers are able to access data, to review it, and to discuss it in order to improve the client health outcome. We also want DHIS to help us to put together, to set up an interoperability of our existing data collecting electronic data collecting tools, and of course to work on improving our quality of data. Thank you very much. This is what I had to share with you. I'll be happy to clarify whatever concern one might have. Thank you.
Good afternoon or morning. My name is Elizabeth DiNenno, and this presentation is entitled Data to Care in the United States, Lessons Learned and Looking to the Future. I am the Associate Deputy Director in the Division of HIV/AIDS Prevention at CDC, and I have several co-authors I'd like to also recognize on this slide. The overview of today's presentation is I'll review the End the HIV Epidemic project and the role of data to care in the United States. Then I'll go through implementation activities in a United States data to care program. I'll address lessons learned and some future directions. There are 1.2 million people living with HIV in the United States, and nearly 14% have not been diagnosed. Around 36,400 new infections occur each year, which is a steady number in the last decade. And only 56% of those living with HIV are virally suppressed, which is why ensuring people who are out of care are able to obtain that care. In 2019, the United States announced a plan to end the HIV epidemic in America, which is a collaboration across many agencies of the federal government and state health departments. The goal is to promote a focused effort in a specific number of counties comprising half of new infections, and to reduce new infections by 75% in 5 years and by 90% by 2030. There are 4 main strategies to the Ending the HIV Epidemic project. One of these, the treat pillar, which is circled in red, seeks to reach sustained viral suppression for those with HIV. And data to care is a key activity to increase viral suppression, thereby also reducing transmission of HIV. We define data to care as a public health strategy using surveillance and other data to identify people with HIV that may be in need of HIV medical care and services, and facilitating linkage to those services. The specific definition of this population may vary from state to state, but generally it's persons not documented to be receiving care by no evidence of CD4 or viral load tests in the previous year. The basic steps of a data to care program in the United States are listed here, and I'll go into more detail about these in the next slides. Before the steps that were listed, there is a preparatory phase. Programs must ensure they have the staff, protocols, and data sharing agreements that are necessary. There also has to be complete lab reporting, because surveillance data are routinely collected by laboratories who are required to report CD4 and viral load plus other information to state health departments. We also need to ascertain data such as for death data to provide specificity to the surveillance system, and other supplementary information. They're all critical to have in place. So next, we would identify our cases to determine a not in care list. A presumptive not in care list is generated by using different criteria depending on different state health departments. What date the care was established, which care markers are being used, and who might be in the population of interest, either everybody living with HIV or maybe those diagnosed more recently. Based on these criteria, an initial list is generated using the variety of data sources, but most importantly, the HIV surveillance system, which is called EHARS. That's supplemented with other data sets. Next, the investigation. We use data sources to actually confirm the vital status, residence, and care of the people in the presumptive list. For this, we use various other data sources like listed here, partner services, search tools online, motor vehicles, or Medicaid data. And we check for potential duplicate records in our national data set. Then we prioritize this data to care list to give out to our field investigators, such as disease investigation specialists, other providers, or other health department personnel. And then finally, we would provide the important work to relink people back into care. I could have spent a whole session just on this aspect, but I will just mention that there are so many nuances to this work. Specialist often has to involve many providers, linkage to care coordinators, and services such as housing, drug treatment, and partner services to wrap around people who are not in care. It's very complicated work. And finally, the information from these specialists is fed back into the surveillance system to improve the data and to include in monitoring and evaluation. It's important to update the cases with the various data points that are listed on this slide. Next, I'd like to share a few lessons learned from data to care, and I'll first discuss the data to side and then to care side things we've learned along the way. The first lesson learned from the data side of data to care is that effective programs rely heavily on the quality of data systems and health departments' capacity to use those systems. Let me give you an example from one of our demonstration projects, CAPAS, which is Care and Prevention in the United States. Here you can see that people we thought were not in care, the 12,000, were difficult to locate and verify their care status. So of those 12,000 persons, only 40% were able to be contacted. And then of those persons who were contacted, 61% were already actually in care. And we determined that by contacting the person and documenting their status. So even after matches with multiple data systems, many people were actually already in care. Now on the to care side, once we have the list and we go do the work, CAPAS showed us that linkage and re-engagement services are resource intensive and they take time. They might not be accepted by all persons. So what you can see here is that of the persons that were confirmed to be not in care, that actually 63% offered, that were offered the service of relinkage to care accepted the service, but 33% declined. And finally, among those that were provided services, 86% were confirmed were re-engaged into care. So that's the success of this program. Once we're able to find people and be able to offer them services, many of them are relinked to care. So there are challenges to our data to care program. Obviously, it's time and resource intensive. Our surveillance data were not designed originally for this purpose. And communication and collaboration with our providers provides new and challenging experiences for some of our health departments. Also, persons who are not in care, as I've mentioned, have complex needs and require additional support. But there are also successes. Among clients truly out of care, programs were successful in linking a majority back into care. It also improves surveillance data. It provides new collaborations. It leverages existing relationships to maximize the use of data. And it provides new models for data use and new data sharing agreements. For future directions, we would say that there are new methods to identify persons out of care. These methods would include not just using surveillance data, but also data from, for example, pharmacies. There are new, novel data sources that might flag when a person does not pick up a prescription and may need some support to continue their antiretroviral therapy. Also, data sharing and data use agreements have been very useful and critical to go forward and to ensure that all pieces of the data are secure, no matter who is touching this information. Also, incorporating models that connect healthcare providers and health departments are important. We've learned that having case conferences between providers and health departments is very useful and beneficial to ensuring that the list of persons are truly out of care. And finally, we have to mention the impact of SARS-CoV-2 on patients in HIV care and the data systems that serve them. It's too early to say exactly how this will affect this program. And I'll just close with mentioning there is a J-AIDS supplement from September 2019 that addresses many of the programs I've just described and some of the demonstration projects. So if you're interested, you can take a look at that. Thank you very much.
Thank you. Welcome back, everybody, and welcome to the question answer session. I hope everybody enjoyed those presentations as much as I know I did. We're going to start off with a question for Dr. Kapanda. Dr. Kapanda, what do you think the role of ministries of health are in driving patient-level data use, and what support do you need from partners and funders to drive patient-level data use?
All right, thank you very much, Kristen. I think the greatest support, the role of the Ministry of Health will be to coordinate, like the effort, to coordinate and make sure that the resources available are used appropriately. Knowing how to direct which resources, where to go. The support that we need to get, I will base it on the experience that we have with working with University of Maryland. They have supported tremendously in terms of bringing in staff, because staff shortage, HR is one of the challenges that we have. Like, we are talking data, but data have to be collected, data have to be entered into a system that is existing, and data has to be analyzed. So at times you don't not only have the people to use, to collect this data and to use it, but you don't also like in terms of expertise, like people equipped with enough expertise to use the data and to analyze it in order to provide guidance to decision makers. And the last thing I would say is the technical assistance in terms of, we do have a lot of systems, like I say, in place, but you find there are places, facilities that lack even in the hardware, like you don't have machines, you don't have computers to use. So the main support will be in terms of technical assistance, HR, human resources, and of course, expertise.
Great. Thank you so much, Dr. Kapanda. The next question, I think, will be for Dr. DiNenno and Dr. Kapanda. From the U.S. and Botswana experience, maybe you could tell us about what kinds of barriers exist with the various data to care programs, and how have programs overcome those barriers?
Okay, I think I can start on that to say the barriers that will put them in two levels. The first one and the very crucial one is the staff, as I mentioned. In terms of staff here, what I mean is collecting this data. You can't have any data to use if the people who are supposed to collect the data are not collecting them. So the stuff, like in our case in Botswana, you find most of the data collection is done by the same nurses. We have the task shifting where nurses are the one who are providing most of the HIV care. So you expect the same nurse to collect data and to see patients and collect data, which becomes a little bit cumbersome. When if facilities, like with the support of University of Maryland in our programs, wherever we have data clerks, wherever we have data collectors, wherever we have someone else who can enter the data in the system and let the nurses do the clinical work, things are much better. The other challenge is the technology, as I mentioned. We still have a number of our facilities which are paper-based, and getting the data from the books or from the register, entering the system, is something that it doesn't happen in many of our facilities. And the multiplicity of data to be collected, so many registers, so many programs, so integration is needed. So lack of integration is another biggest challenge to properly collecting and using data.
Yeah, and I'll just join in to say that I think the major barriers for the US system and our state health departments is, first of all, the quality of the data. Even though we have data that are required to be reported, address data, just data across state systems, that can be very challenging to make sure it's all accurate. So we have a lot of systems in place. We find that after data to care systems are conducted, that improves data considerably going forward. So luckily that improves over time. And I'll just say the timeliness of data is a real challenge to make sure we're getting the information in a timely way out to our disease and investigation specialists so that they can go in a timely way and find persons to get them back into care.
Great, thanks, Liz. And now, Dave, over to you. Along those same lines, but moving more towards the use of the data in particular, what do you think are the maybe greatest strengths, things that have worked well, and what are some of the barriers to the use of individual level data to improve patient care and health service quality?
Thanks, Kristen. So as you can imagine at WHO, one of the things we do consistently is to monitor the uptake of our recommendations. And in this case, our recommendations on the collection and the use of data. So if you look at the history with regards to our guidelines on data, go back to 2006 when we issued the first patient monitoring guidelines. We know that in low and middle income countries, patient monitoring has been widely adopted, and historically it's been reflected largely in paper-based systems with this slow evolution towards digital systems. Now, when we think about case surveillance, for example, we note that we didn't come out with guidelines until 2017. And you commented earlier on the fact that there's been a fairly rapid evolution relative to wealthier countries, upper income countries. But the fact is that even in these countries that have seen some success, it's taken them time, and it's been really, I think, a matter of the health information system. So you take a country like Malawi, started one of the most effective M&E systems with their patient cards, very simple minimum data set, using those data for national reporting very powerfully to drive program improvements. Back in 2006, when I was working in the country, there were 2 centers of excellence that had digital systems. Today, you have an EMR-like system that's got over 50% of coverage in the country and development of unique identification. And I think you're seeing that more and more. Countries that have been most successful have figured out how to handle issues around data standards. They've developed policies on data exchange to facilitate interoperability. And in some manner, they have addressed the issue of unique identification, not necessarily in a, let's say, in a fancy, necessarily sophisticated way, sometimes in very simple ways, but they've addressed unique identification. And I think the countries that are probably the furthest ahead at achieving a vision for collect once, use many times are the countries that have really taken on these challenges of interoperability and unique identification to the greatest degree.
Thanks, Dave. And just as a follow-up, how does the data to care model fit into the WHO guidelines on HIV strategic information?
Yeah, no, it's a very interesting question, and one that I was struck by when I was invited to join this session. As I reflected on that, and I think about the data use cases that WHO has historically defined in its guidelines, including in the pyramid slide that I showed in the presentation. I think what data to care is a blend. It's a hybrid of sorts, and it's, let's say, the next stage of evolution and how we think about individual level data. Ideally, we wouldn't be breaking data into these discrete use cases, patient monitoring and case surveillance. There would be simply individual level data that could be used to address multiple uses, starting with patient care. But for example, where you don't have a system that's totally effective at providing decision support, it's not necessarily generating the health alert to the provider real time at the point of service or within that health facility, then you have a system that's also enabling administrators, surveillance officers, or program managers at the district level to pick up on the fact that PLHIV on ART have been lost to follow-up and at a facility, and that data still is quite actionable even at the individual level, and that could even go up. That example could be extended to higher administrative levels, but ideally there's less of the splitting and more of a common sense of utility, starting with the patients and even with program management or program monitoring, really bringing it back to what is fundamentally person-centered care.
That's great, Dave. Thanks a lot. So I have a question that for the three of you. We've talked a bit about the systems. We've talked about the human resources and how the data gets used and the guidelines. But I wanted to ask each of you, how do you see and what do you think we need to do to ensure that the patients themselves are better engaged? How do we get community level representation and input into these systems that we're trying to build? Max, would you like to go first?
Well, thank you. Yes, I think the patient is key in fact in this. When the patient understands that we need their input in terms of them coming to collect the medicine, for example, they're coming to the clinic. They're not using respecting the follow-up. Lab monitorings and whatever, because we need that to make decision. That can only go through health talks. Health teaching our patients about the relevance of the information that we get from them, because generally they don't know that we need this in order to plan ahead. So I think it goes a lot to say it used to be a good portion of patient education in terms of adhering to treatment, retaining themselves, remaining into care for as long as possible, and complying to adhering to whatever the clinicians are telling them to do, because that's how we can get good data. That's how they can participate. Thank you.
Liz?
Sure, that's It's a really important question that you asked. I think probably the most critical to this whole endeavor, honestly. I think what we're trying to continually improve on is building, not just ensuring that the patients feel that this is just an HIV-centered activity, but really building social systems around a person. So we're providing not just, we're not just trying to make sure that person is virally suppressed, right? Because all these things go together. So really providing wraparound services and making it clear to our, to the clients that we're here to serve all of your concerns, and we're going to build systems around you to ensure that you can stay in care. And so that's a real challenge for all of us, but I think that's the critical piece to ensure that patients understand it's patient-centered and it's not just about HIV.
Dave, any thoughts?
Sure, thanks. Really great question. Yeah, let me quickly highlight two different angles on that. One, Rich Lester and colleagues have done some work that for me has really kind of informed our thinking about person-centered patient monitoring. And it's something as simple, an intervention like sending it to PLHIV on treatment, just saying, how are you? And having the patient receive that and openly able to reflect on what that means to them and to characterize their own state of well-being. And then that can be brought into more formal, monitoring frameworks, if you will. But I really like that. And then the other thing I wanted to highlight is probably one of the most critical recommendations in our recently launched in April of this year, HIV SI guidelines, which are the aggregate indicators. But it's this notion of routine data use. And what it calls for is at country level convenings by the ministry, but in very representative ways. So convenings around all of the program data and the cascade data and the disaggregated cascade data, but with community and civil society, with district and facility level staff, and with implementing partners and donors, everybody at the table, but where the ministry facilitates a conversation about which data are most important, which disaggregates, how they should be looked at, how they should be interpreted, and how they should be applied to improve programs. And I really feel like when community and civil society and more broadly, stakeholders have a sense for what these data can do to improve programs, then they feel more invested in it. I mean, I think it's been documented time and time again. When people see applied data use, they understand the importance of the data that's being collected and reported. So thanks.
All right, thank you all very much. We have about 30 seconds left. I just want to thank everyone for their participation. Dr. Swaminathanf, all of the panelists for your excellent work and presentations. And Mahesh, do you want to close it out?
No, thank you once again to our presenters. And I think this is a fantastic session. And I'm really looking forward to the concept of this data cycle to benefit both patients and national programs moving forward. Thank you so much.
Thank you all.